When a kid has a painful, swollen joint, that's an instant red flag, right? For any parent, for any doctor. But what does it actually mean? Well, today we're going to dive deep into the really complex world of pediatric rheumatic diseases. We're going to try and figure out what happens when a simple ache turns out to be something a whole lot more. And it almost always starts in such a common way. You see a kid limping, maybe they're complaining about a sore knee or an ankle, and your first thought is, oh, they probably just fell, or they must have twisted it playing outside. I mean, that's just a normal part of being a kid, isn't it? But then, what if it isn't just a simple injury? What happens when that swelling just sticks around, or that morning stiffness seems to get worse and worse, and the pain, well, the pain becomes this constant companion? See, that's the point where we have to totally shift gears and start asking some very different questions. All right, so let's get into the nitty-gritty here. The actual clinical definition of arthritis is super important. We're not just talking about any old joint pain. What doctors are looking for is real, objective swelling, or a limited range of motion that's also painful. And here's the kicker. It has to last for at least 6 weeks. That 6-week mark, that's the line in the sand. It's what separates a simple sprain from a chronic inflammatory process. Okay, so once the word arthritis is on the table, that's when the real detective work kicks in. And trust me, it's a genuine diagnostic puzzle. Why? Because a swollen joint in a kid, man, that can be a symptom of so many different conditions. And just take a look at this list. I mean, the possibilities are incredibly broad. It could be a reaction to a recent infection, it could be a sign of something like inflammatory bowel disease, or it could be something really serious like septic arthritis, or even cancer. Every single one of these has to be carefully considered and ruled out. And this right here, this quote from our source, it really hits home just how high the stakes are. Some types of childhood arthritis can look almost exactly like leukemia at first, with the fever, the pain, the weird blood counts. This is precisely why a thorough, careful evaluation is just absolutely crucial. So after you've ruled out all those other potential causes, the investigation usually starts to narrow, and it often points toward the most common chronic rheumatic illness in children, juvenile idiopathic arthritis, or JIA for short. So what is JIA? The name actually tells you a lot. Juvenile means it kicks off before age 16. Arthritis, well, that's the joint inflammation we've been talking about. But the most important word in there is idiopathic. That's just a fancy way of saying we don't know the exact cause. It's what we call a diagnosis of exclusion. And you might be thinking, this is super rare, but it's not as uncommon as you might think. With an incidence rate of up to 22 per 100,000 kids, it's a pretty significant chronic disease of childhood. Now, the leading theory is that JIA is an autoimmune disease. Basically, the body's own immune system gets confused. It gets its wires crossed and starts attacking the joints by mistake. And we think this whole process might get started or triggered by something like an infection or another environmental factor in a kid who's already genetically susceptible. Here's where it gets really interesting, though. JIA isn't just one single thing. It's actually an umbrella term for a bunch of different subtypes, and each one has its own personality, its own features, risks, and outlook. Let's start with the most common one of the bunch, oligoarticular JIA. Oligo just means few, so this type affects 4 or fewer joints, usually the big ones like knees or ankles, all within the first 6 months of the disease starting. But here's the thing about oligoarticular JIA, and it's a big one. The most serious danger isn't even in the joint. No, it's a silent, totally asymptomatic inflammation inside the eye called uveitis. You can see here how it can make the pupil irregular. If you don't catch this, it can lead to permanent vision loss. And that leads us to this. This is a non-negotiable rule in pediatric medicine. Because that uveitis is so sneaky and silent, every single child diagnosed with this subtype has to have regular eye exams with an ophthalmologist. It's absolutely essential. Okay, let's switch gears to a totally different subtype, systemic JIA. This one can be tricky because it doesn't always start in the joints. One of the classic clues is this fever pattern you see. It's called a quotidian fever. You get these high spikes once, maybe twice a day, often around the same time, and then the temperature drops right back down to normal or even below normal. And clue number 2 for systemic JIA is this really distinctive rash. It's a faint, kind of salmon-colored rash, and it's famous for being evanescent, which is a great word. It means it just comes and goes. It typically shows up when the fever is at its highest point, and then, poof, it vanishes as the temperature comes down. This table gives us a great snapshot of the other main players. You've got polyarticular JIA, which affects 5 or more joints. It comes in 2 flavors, one of which is a lot like adult rheumatoid arthritis. Then you've got psoriatic arthritis, which is linked to psoriasis and can cause this sausage-like swelling in the fingers or toes. And finally, enthesitis-related arthritis, which attacks the spots where tendons attach to bone. So, with all these different ways JIA can show up, how in the world do doctors actually nail down a diagnosis? Well, it's all about assembling the pieces of the puzzle over time. And here's the thing to remember. There is no single blood test that screams JIA. The diagnosis is mostly clinical, meaning it's based on the patient's history and the physical exam. Now, lab tests and x-rays, they're really important supporting actors. They show us how much inflammation is going on and, super importantly, they help us rule out all those other scary things we talked about earlier. And this is what we're trying to prevent. You can see here what happens over time if that inflammation just goes unchecked. Early on, an x-ray might just show a bit of swelling, but down the road, chronic inflammation can literally eat away at the joint, causing the space to narrow, creating erosions in the bone, and eventually even causing the joint to fuse together completely. So, because that risk of permanent damage is so real, the goals of treatment are about way more than just pain. Of course, we want to control pain and inflammation, but it's just as important to preserve that child's ability to function, to play, to go to school, and to grow and develop normally. Before we wrap up, I have to talk about one last thing. It's a critical warning about a rare but incredibly life-threatening complication that's mostly associated with systemic JIA. It's called macrophage activation syndrome, or MAS. Think of it as a catastrophic, widespread activation of the entire immune system. The diagnosis gets pretty specific, relying on these lab criteria. First, you need a sky-high ferritin level. Then you need at least 2 other problems from this list, like a plummeting platelet count, angry liver enzymes, or crazy high triglycerides. And this is exactly why it's so important to know about. If you have a patient with systemic JIA who suddenly gets much, much sicker, whose fever stops spiking and just stays high, you have to think about MAS immediately. Because, and this quote says it all, if you don't catch it and treat it aggressively, it can be fatal. It's a powerful final thought, isn't it? A stark reminder of just how serious a swollen joint in a child can really be.